Good afternoon. Thank you all for joining us. My name is Dr. Paul Chittister. I'm the Vice President of Medical Affairs at Sentara Norfolk General Hospital, our main teaching hospital within Sentara Healthcare. Also with me today is Evelyn Olenek, one of our nurse executives who's partnered with us on our glycemic journey, and also Millard Trimble, our Director of Information Technology, which has been a key point in our glycemic control journey. We're really excited today to share with you some of our initiatives within Sentara Healthcare over the last 3 to 4 years, as we've really worked very hard to improve inpatient glycemic control. And we've been really pleased to partner with Glytec, and we've begun to launch the Glucomander software. So today I'd like to share with you what our journey has been, and then also the role that Glytec has played as our partner in this implementation. And it's important to disclose at the beginning of this discussion that we're really sharing our successes with you today. We're not receiving any support from Glytec. We just feel that we're proud of where we've gone so far, and it's worth sharing some of our lessons learned, and hopefully that in the future you can look forward to similar successes and maybe avoid some of the obstacles that we've had over the years. This slide just shows a brief overview of Sentara Healthcare. We're a 125-year-old system beginning in Norfolk, Virginia. We've expanded over the years to now 12 facilities. Actually, our 12th facility will be joining us in the first of the year. We're a very integrated healthcare system. We also have about a 450,000 member health plan, a medical group with about 500 providers, 7 skilled nursing facilities, home care, an LTAC, and DME. So we like to think that we're quite integrated in the delivery of care to our patients. And in general, what I'll be discussing today with our glycemic control initiatives, they've really been focused around 8 of our acute care hospitals that you see listed up there, as well as a number of freestanding emergency departments. And the next slide sort of just summarizes what our journey has been to date. Back in 2008, we identified some real gaps in the care of our inpatients with diabetes. As a result of those gaps, we formed a glycemic control committee that was multidisciplinary and really worked to standardize care, reduce variation, and really begin to measure our improvements. We sort of fell off point a little bit in 2010, 2011 as there were a number of competing priorities. A number of the tools we developed, although were useful, they did not really anticipate further decrements in the control of the glycemic patient, so a patient would not always get their insulin dose modified the way it should. We again felt that technology was a key part of this. I should digress just to say that we do use electronic medical record at all of our hospitals. This electronic medical record is for all aspects of care and documentation. We have 100% physician order entry and all physician and nurse documentation. We're as close to paperless as I think we can be. So we, again, relying on information technology, we developed an IV calculator within our EMR, thinking that might be the answer, but still that did not get us to where we needed to go. So throughout much of 2012, we spent time building a case to purchase Glucomander for use at all of our hospitals where we have an EMR launched. And then we've been doing this implementation for the intravenous module of Glytec over the last 5 or 6 months, beginning in April of this year. We look forward to then launching a subcutaneous module beginning next month at one of our hospitals, and hopefully have this in place through the first quarter of 2014. This next slide is a summary of what our journey has been to date. You can see on the blue bars for both hyperglycemia, or glucose is greater than 180, on the left, you see that nationally the average is around 40% of the glucoses in hospitalized patients are greater than 180 milligrams per deciliter. Likewise for hypoglycemia, about 10% of those values are less than 70. We weren't quite that bad when we began our journey back in 2008, but our hyperglycemic rate was quite variable within our hospitals, and it varied from around 20 to 35%. And hypoglycemic rate was at around 3%. Through the work of our Inpatient Glycemic Control Steering Committee, you see we were able to reach a nice reduction in the level of hyperglycemia and hypoglycemia, such that we were, for hyperglycemia, we were down to 18% in late 2009, early 2010, and for hypoglycemia, we were 1.2%. Again, with conflicting agenda items and some failure to really continue to drive improvement through our medical staff and have tools that would continually adjust insulin dosing, we fell off somewhat, and you can see that both of our rates increased. And it was with this increase and failure to really make any improvements with other process changes that we elected to then move forward with Glytec and the Glucomander software. And as you can see, there's two subsets of patients listed there that have used the IV Glucomander module. The system results were sitting at a hyperglycemic rate of 13% for the first 90 days of implementation of Glucomander. And one of our hospitals, Sentara Virginia Beach General Hospital, has a rate that's even lower. And the reason for that is that we have been using Glucomander there for quite a few years. In fact, some of our endocrinologists at Virginia Beach General were instrumental in the development of the Glucomander algorithm many, many years ago when it was a DOS-based program. So they were somewhat familiar with it, but they also saw some nice improvements. And then the thing that is very compelling to share with particularly our medical staff, is the incidence of hypoglycemia, because there's always a lot of pushback to using tools to tighten up control at the expense of patient safety in developing hypoglycemia. But in fact, we were able to have a marked reduction in hypoglycemia with the use of the Glucomander application. So some of the things we want to talk about today are outlined in the next slide. Really some of the problems that we had that really were our burning platform to begin our journey to improve glycemic control. Some of the steps we took, again, a little more detail around where we fell off, some of the work we did to then make a decision to partner with Glytec. Again, a key component of all of this work is that what we would do would be integrated within our electronic medical record. Again, we use Epic, if I forgot to mention that earlier. And then want to share with you what some of the end users say about the experience. And then some lessons learned that may be useful for you for your implementation, should you choose to use this product. One other point I forgot to mention at the beginning of this discussion is if you do have any questions, we'll address those at the end, and there's an area within the webinar where you can type in your questions, and again, we'll go through those at the end of the talk. So the next slide talks about really our burning platform, our problem. And being very transparent, what really got us going with our journey was that we had 2 patient deaths from prolonged hypoglycemia. And we realized in doing an in-depth analysis of those 2 events that our staff really had quite a variable level of knowledge in how to manage diabetes. There was gaps in knowledge of the duration of action of insulin, the time that it should be administered, what proper control looked like, and we really just saw a lot of variability, a lot of gaps, and a lot of opportunities. We were using sliding scale insulin for the care of all of our patients. Basal bolus was not the standard unless perhaps there was an endocrinologist involved with the case. And then looking at that variability, we can see that this puts our patients at quite a bit of risk, given that it's a high level of hyperglycemia, a lot of variability in how we're treating it, and then the fact that so many of the patients that are admitted to our hospitals have diabetes to begin with. but that's not the primary reason for their admission. So about a third of our inpatients have diabetes, generally as a secondary diagnosis. A small percentage do have diabetes as their primary diagnosis, likely those that are coming in with DKA or hyperosmolar state. So again, diabetes is a big problem for our inpatient population, but it's not something that we were consistently or adequately addressing. Some would say that the diabetes was more of white noise with our patients. The poor control was just sort of the status quo. Episodes of hypoglycemia were considered almost a rite of passage of being in the hospital. These events just happen. It's bound to happen because it's a different environment for the patients. So again, feeling that we were not paying attention to the detail to really provide the care that our patients deserved. And as a result, began to embark on our journey to improve care. Next slide, please. Shows some of the things that we did in the beginning. We developed a inpatient glycemic steering committee that was system-wide, had representatives from all the hospitals that were in the system at the time. When we began this journey, there were 7 hospitals in our system. And at the time we began the journey, we did not have EMR launched either. It was launched at one of our sites in early 2008, and then through 2009, the EMR was launched everywhere else. So we were working in both the paper and the electronic world. So we got this, brought this committee together that involved representatives from all the sites. In addition, it was a multidisciplinary group, so we had physicians, we had nursing, we had pharmacists, we had diabetes educators. At times we brought in people from food service when we were dealing with issues around the menu and meal delivery. So really involved everyone that was necessary. In addition, information technology staff were a vital component of this. The individuals that were developing order sets in the EMR were also involved. And we began to track our metrics, again, because prior to these several deaths, we never really even had an idea of our hypo and hyperglycemic rates. And in fact, we did a deep dive into hypoglycemia, and we saw that we had patients that were being treated 10, 15 times during a single hospitalization for hypoglycemia. So our first task was really to work to reduce the incidence of hypoglycemia. And we treated an episode of hypoglycemia as an event, not just something that happens in the hospital. We had huddles on the nursing units the following day if there was a hypoglycemic event, and looked for key factors that could have been causing the event. And that data was then summarized, aggregated, and shared with the Glycemic Control Steering Committee so we could learn where there were gaps in our processes. We also wanted to get a better idea of what our staff knew, where we should focus our education. We sent out a survey to all disciplines and basically just asked them questions about diabetes, and simple questions. How long does NPH insulin last? What is the cloudy insulin that you're giving the patient? How many times a day should you be giving insulin? What is the desired range of control for your patients? Really basic kind of questions, and it was surprising how many people did not know the answer to those basic questions. And I think that it served 2 purposes. Folks learned that they did have some definite gaps in their knowledge, so they were more receptive to learn. And then we also knew where we really needed to target that education. And we really pushed education throughout the system in various levels. We had lunch and learns for physicians, for nurses. We had grand rounds. We brought in a lot of guest speakers and really made diabetes control top of mind. At the same time, we were really rolling out the concept of using basal bolus insulin and eliminating the sliding scale of insulin. So really, it sort of took a real across the waterfront approach to education. At the same time, we were working on some process changes. In addition, we started to track our metrics, and we put them on our system dashboard. We have a red light, green light report that has about 30 different metrics around core measures, patient safety, falls, pressure ulcers, hospital-acquired infections, and we added glucose control to that dashboard, the incidence of hyperglycemia and hypoglycemia for each of our hospitals. So that was out there so that folks could see really where there were areas of opportunity. And then we also developed more data to get unit-based reports. So each nursing unit had an idea of what their incidence of hypoglycemia and hyperglycemia was. As a result, really, shed some light on the problem. So then at the same time as we were doing all this education, we made an effort to eliminate sliding scale insulin. We did this one hospital at a time. Within our electronic medical record, we developed a really easy-to-use, weight-based basal bolus insulin order set so that physicians with limited knowledge on how to really dose these folks were given step-by-step guidance through this order set so that the initial doses were fairly easy to calculate and safe, and physicians could then also select what type of insulin sensitivity they thought their patient had so that the corrective insulin would be appropriate as well. So it really was an easy order set to use compared to something that existed in the paper world beforehand. I'll digress. And initially, when we started our steering committee activities, we just sort of were saying to our patients, to our physicians, why are you using sliding scale? We have this great basal bolus insulin order set. It was more on paper, it wasn't easy to use, and they said it just doesn't make sense what you have out there. So we developed this new order set in the EMR that, again, was much more user-friendly. At the same time, we developed dosing cards for all the residents and other physicians, developed PowerPoint training modules, and basically at one hospital at a time, we would launch the basal bolus insulin order set. We still had sliding scale there at the time we launched the order set, but what we did was if a physician selected sliding scale insulin, they would get an alert that would say, you are not using the current evidence-based therapy, click on this link and we'll take you to the order sets you should be using. And then we also said on this alert, and by the way, the order sets you're using will be retired in X number of days. And we did this over 30 days at each site. And while we were making that transition, we would look at order set use for both sliding scale and the basal bolus. And if we saw pockets of still high utilization of the sliding scale, we would have additional targeted education for those physicians or those physician groups. After we had that education, we could see the basal bolus order set rise. So we did this hospital by hospital, and with a period of about 3 months, we eliminated the use of sliding scale insulin altogether and used just basal bolus insulin therapy. The one problem we found over time with that, however, was physicians could select the basal bolus insulin order set and just select corrective insulin. So we also had to work through that to increase the use of the basal insulin with that. We did a lot of marketing as well at the same time to promote awareness. We had buttons that the red SSI with a line through it as to no SSI use that even our hospital presidents were wearing. So clearly leadership from the top made this a priority. And then we worked with care coordination to help transitions of care. We developed a discharge order set for diabetes so that the proper insulin would be ordered at discharge, and all the right other things such as insulin syringes and lancets for AccuCheck, et cetera, were there. So we really made some nice progress. We saw improvements, as you saw in the first slide with our data, but over time we saw some slippage. And basically I think that some of the things that contributed to that slippage were that physicians weren't always using the order set properly, or if they did order basal insulin at a specific dose on day one, they basically set it and forget it and didn't make any additions to the change in basal insulin over time. So they stayed on this insufficient dose of basal insulin and never really stepped it up as they should have. Again, some physicians were doing a little bit of a workaround and not even ordering basal, but just using the corrective insulin. And they were also selecting the wrong corrective insulin. They were be afraid of hypoglycemia, so would select the range for as if a patient was very sensitive to insulin, when in fact they were not sensitive to it. Should have had a higher dose of corrective insulin used. And then we were using our own homemade IV insulin calculator that again did not seem to be adequate, particularly compared to what Glucomander could deliver. So we actually embedded an IV calculator into our EMR that we built as an algorithm off of our own IV insulin order set. And it made it easy for nurses to type in the glucose result and get an IV insulin dose adjustment. But when we compared the results in those ICUs versus an ICU at Virginia Beach General that was using Glucomander, our results were inferior. And whenever we went to patients saying, we really need your assistance in using this order set properly, quite often the response was, why can't you just make this more a computerized algorithm for us that adjusts as needed? So with our inferior results with our own IV calculator, with the feedback from the physicians, with our slipping results overall, we made the decision that we needed to go to the system leadership and make a case to get to get Glucomander for use of both IV and sub-Q therapy. The next slide sort of just highlights again some of what our barriers were. Again, I think probably some of the biggest ones are the lack of knowledge of really the right way to treat diabetes, and then not listed there, but we have a lot of staffing turnover. At some of our hospitals, particularly Norfolk General, we get a lot of new grads. We have over 100 new residents that come every year, and getting them up to speed consistently with the right way to manage diabetes is a chore. And I think that's another part of our slippage is as we had turnover, we had people coming on that did not have the knowledge base that they needed to. And then again, the way that folks could slip back a little bit into the use of sliding scale insulin. So these are just some of the barriers that we identified and felt that what we were doing currently was just not solving the problem that we needed to. So we decided to move forward and request funding to use Glucomander system-wide. And we put together a real business case to our system leadership to get approval for this. And we made sure we did it during the budget planning so that it was easier to accept. Off-budget cycle requests are often difficult to get approval with. We made sure that it was going to be completely interoperative with our electronic medical record. We have a really strict IT department that's not about to just throw on another application or after application into our system. We want ones that are very operable with our current system. We wanted something that really gave us a lot of data feedback, so we had an idea of where our areas of opportunity were within various nursing units or various physician groups. And we wanted something that was really very simple for the end user to use. We looked at a number of different products, and Glucomander just really gave us the web-based platform that would integrate with Epic, and made the case to our system leadership to get funding for this. We gave them a business case looking at the fact that reducing length of stay by by reducing glucose by 10 milligrams per deciliter on average. Studies have shown that reduces length of stay by about a quarter of a day. We also anticipated reduced point of care testing and the approximate $5 cost per test that costs. And then the other downstream improvements with potential for reduced infections, improvement in our skip metrics, and possibly reduced readmissions, all made for a very good case to our system leadership to approve this. So we were very excited to get that approval, and then our next step was really to be partnering with our IT staff to get this system fully integrated within our Epic platform. So now I'd like to turn over the presentation to Miller Trimble, who's our Director of Information Technology, and who's just been an incredible resource in getting Glucomander into our electronic medical record. Miller? while a key component of this whole implementation has been the integration within our electronic medical record, clearly the other part that's huge is the impact on the end user. And we had to design all of this with our nursing staff in mind. So with that, I'll have Evelyn Olenek, a nurse executive from Sentara Careplex, who's been a real partner with me on this journey, introduce some of the lessons learned that she's had with this implementation.
Thank you, Dr. Chittister. And definitely within any hospital, your largest workforce component is, of course, your nursing staff. So when Dr. Chittister had brought this forward to our clinical leadership, we looked at the business case, but we knew ultimately the impact on patient safety. And so there was unanimous agreement that we move forward with this. But where do you begin? And of course, needing to partner not only with our clinical leadership, but with information technology and Glytec as well. So we did consider it a partnership with Glytec, although we were the lead and Glytec was more of that supporting role than versus the other way around with the vendor. That is very important, that the clinical leadership has to embed this, has to have this as part of the value for patient safety and begin that journey, because it's important for your entire workforce. So the Sentara IT clearly partnership with Glytec, and we also found that we needed to create a deeper integration with Epic for nursing so that ultimately Glucomander can be accessed in the physician and nursing Epic screens. Glucomander orders are built within the Epic context, and Glucomander can be started on patients in 2 minutes. I was speaking with one of our nurses from Virginia Beach General, where they have years of experience working with Glucomander, and Colleen has identified that her role as a nurse has been so unencumbered by use of this particular tool because of the fact, the ease, and because it's very dynamic and it's real time based on the patient's physiological condition and response to therapy. The key stakeholders had to come together. We formed our own project management oversight team, including physicians, nurses, pharmacists, educators, diabetes educators, dietitians, information technology, and Glytec. And we knew that we had the overall intent and the mission to create a very structured workflow with regard to ensuring that the education was disseminated throughout our entire workforce. And when the day is done, we educated nearly 2,000 registered nurses, and about 450 of those 2,000 were super users. And the nursing response has been very favorable to the use of Glucomander, and is identified for the more experienced registered nurse. They're able to start the program within 2 minutes, and probably the staff that are more unfamiliar, still in that learning curve, it takes about 5 minutes. So you can see it is very efficient. And it really is, it's a dynamic software tool that enables the nurse to use technology and providing safer care for IV insulin management. It's about giving the bedside nurse the right technology to assist in their workflow and decision making. Hospitals are complex adaptive environments and systems, and so how do we as leaders empower the nurse, educate that nurse, and give the frontline caregiver that appropriate tool so that they're able to better partner with physicians, pharmacists, and other members of the team across the care continuum and breaking down those silos. The role of leadership must be actively engaged, and the entire glycemic control project, there was a true partnership. It's about inspiring the clinicians, leading toward that culture of safe care, a culture of accountability, and capturing the feedback from the frontline caregiver. How can we make your work easier, less complex in a highly complex environment? There's a number of interruptions, a number of workflow issues that have to be addressed. So it truly is getting the feedback from the bedside nurse. How do we empower you and hear your voice so that we could change and help you manage the workflow for better patient outcomes? The role of the chief nursing officer in any hospital is really to set the vision, but it's also to drive the results and to enable your leadership team and your frontline caregivers to give them the right tool. How do we shape that workflow? How do we bring about better care in an environment where we're creating better value and moving from just volume to looking at true outcomes? Safer care across the continuum, enabling the frontline caregiver to break down those silos, hear the voice of the clinician. Where do we make it better? And we were able to partner with Glytec as we were working through the educational process, working through some of the rollout. We used our expert clinicians at Virginia Beach General, where they had years of experience, using that team as our role model to partner with the other hospitals and say, wait a minute, this is a great tool, and you'll find you're going to have better IV insulin management and glucose control to provide better, safer care for your patients. And ultimately, it's creating that patient experience, and overall, it does relate to safer care, quality outcomes, and ultimately more cost effectiveness.
Great. Thanks, Evelyn. Yeah, it's been a real partnership with nursing, with IT, with Glytec to really get where we needed to go. And clearly, it was key to have nursing with us from the very beginning because there were definitely some workflow issues that we assumed would be fine, but we needed to modify with nursing. And in addition, as far as the training, we spent a lot of time developing a training video for nursing that, again, in partnership with Glytec through our nursing leadership, that video was modified quite a few times to really hit on the high points. With this journey, and if you're interested in proceeding with use of a tool to help manage your glycemic control, it's going to take more than the tool. It really involves close attention to what all of your processes are and a process improvement approach. And the tool is just a hardwiring piece of what you want to do to achieve your goals. The thought that you can just go out and purchase a plug-and-play piece of technology and then your solutions will be solved, I think would be a bit on the naive side. And it really takes a village, a multidisciplinary team to work together to really drive improvement to your goal. The one other slide I just want to review again where we've gone over the past 4 to 5 years, and I would hope that in the next 6 months we can start to show even further improvement for all of our hospitals once we've launched our sub-Q module. So with that, I think we have a few questions to review. The first one is, are there residents in your hospitals? At Norfolk General Hospital, our largest flagship hospital, we do have residents. We have residents in basically all disciplines, and large medicine, surgery, OBGYN, and they all have been involved with Glucomander. And actually, given that generation, they just jumped right into it and had no issues at all. The next question I see is, which physician group had the most concern? The physician groups that had the most concern were some of the critical care physicians, particularly those that were familiar with some of the literature talking about the concerns with too tight of control in the critical care units. And again, being able to share with them that with this tool, even though the control was tightened up, we had no increased incidence of hypoglycemia or even a reduced incidence. There was some buy-in there. And then finally, we had one group of physicians that thought that by using this software, they may be at increased liability since now the control has been given up to a computer and they're no longer titrating the glucose management. And actually, I think, again, showing to them that the control improved rather than deteriorated basically quelled their fears. And I think we may be getting to the point where you could even say to them, well, you're not at the standard of care if you're not using this device. The next question I see is, you have rounding endos at each site. I believe we have them out of our 8 hospitals. I believe we have them at 6 of those hospitals. Although we do have rounding endos at each site, even with the endocrinologist, particularly on our cardiac surgery unit, we still were not having the desired control that we needed, and we were having fallouts for our skip metrics, even though endocrinology was following these patients closely. Since we've launched the Glucomander software, we have not had a single fallout on our skip metrics for our cardiac surgery patients, which is really phenomenal.
Take this one.
Okay, go ahead, Evelyn. The
Okay.
next question, do you have IV outside the ICU?
In Virginia Beach General, they do have IV insulin management on a general medical surgical nursing units in addition to the ICU and step down. At our other hospitals, it is primarily at this time all in the ICU and intermediate step down type units.
But actually, we see IV insulin use increasing in the intermediate step-down units now that the Glucomander is available, because it's so much easier for the nursing staff to manage these patients rather than having to go to the paper protocol and or multiple phone calls to the doctors.
Correct.
The next question, do you have teams that daily review glucoses and take action? We're not actually at that stage yet. Some of our diabetes educators will review abnormal glucoses on a particular units, and will then identify those patients, and will follow up with the physicians. Again, often those physicians are not receptive or understanding what the questions that the educator may be making, so they're not always successful in making changes there. Very soon we'll be able to aggregate data through Glucomander, so we can look at it by physician, by patient group, and give that feedback. We've begun to have some performance standards in our critical care units for our medical directors to have a target range for glucose, and having those performance standards has also resulted in a lot of buy-in with this product. One of the things that we're challenged with at times in the ICUs is that patients will be sitting there with glucoses in the 250 range, and the intensivists feel that that's okay. They're scared of tighter control and will not start more intensive therapy. Now that we're really trying to target tighter control, we're getting more use of the Glucomander to get to that control. Is there a trigger for the hypo review that you spoke about with patient cases? Whenever there's D50 given on the inpatient units, this is something that's mentioned in the patient supervisor's report that we see the next morning. It's logged into our event reporting system, and while we're not spending as much time reviewing each case, we are tracking these cases and considering them. Again, not just a rite of passage, but clearly an event that we need to be tracking. So anyone that's getting the D50, the sugars are less than 70, they're getting a look at. The other thing I think that's interesting to mention around Glucomander is that when the patient on Glucomander is hypoglycemic, you're given a specific dose of dextrose to give the patient. So you're not living with an episode of hyperglycemia after an episode of hypoglycemia. So you'll get a dose of, say, 32 cc's of the D50. So it's a much better way to manage hypoglycemia. The next question is, how do you convince management to invest in improving glycemic control? Again, it's there's the soft outcomes that unfortunately are difficult to sell, difficult to measure, and difficult to attribute to improved control, such as infections, readmissions. And it is really trying to make the business case with reducing length of stay, improving the skip metrics, which do have a dollar value tied to them, reduced point of care testing, and then I think the whole concept of improving workflow and reducing interruptions. That's a real priority for our company right now, is reducing the number of interruptions that nurses and physicians have. And the feeling is, using a tool like Glucomander, the interruptions really decrease, because rather than a nurse having to pick up the phone and call a physician for some dosage adjustments, they're given to them through the tool. The next question is, have you done any outcome assessments with Glucomander to date, particularly regarding mortality, readmissions? No, we have not, but we're in the process of launching a study to look at that. We have the luxury of a long period of time without glucomander, particularly through the end of 2012. And then we're looking forward to comparing those outcomes with those in 2013, a defined period once we've launched it everywhere. And we do plan to look at mortality, readmissions, length of stay, and other outcomes, particularly with cardiovascular patients. So we clearly look forward to showing perhaps some improved outcomes with improved glycemic control, and that makes even that much more of the business case. Next question is, did you change your staffing model to implement the software? And no, we didn't. We did not. We, again, part of the implementation was done with our partnership with Glytec. They had a lot of resources there on the front line for us to help with the training and troubleshooting. But there was no additional staff at all. Nor is there any thought that, okay, this tool works great, it's going to improve workflow, maybe we can modify staffing patterns after the implementation. Absolutely not. We're not going to look for any post-implementation staffing changes. The next is, does glucomander work for patients on steroids and renal function? Definitely for steroids. That's one of the buttons that's selected when you're ordering the glucomander to begin with. Although it doesn't necessarily know about renal function, the neat part about the tool is that, yes, the physician will select a specific insulin sensitivity desire when they're ordering the glucomander, but really that's only a starting point, and the glucomander is smart enough that it sees the insulin sensitivity as the time marches on and adjusts its algorithm appropriately. So that the renal function piece of that would fall right into that bucket as well. And then the last question is, how do you utilize diabetes educators with this new model? Evelyn, do you want to tackle that one?
It's a partnership. Our diabetes educators, although this enhances their role as they're working with the staff about education, it really also helps them educate the patient as well. So their role has actually been enhanced with this dynamic tool as well.
Yeah, they were clearly wanting this tool. There's no doubt.
Absolutely. It helps them as they're providing that education, once again, to the staff as well as to the nurse, and then partnering with all the disciplines, medicine, nursing, pharmacy, and most importantly, the patient.
Excellent. So I think we'll close this session now. I want to thank everyone for participating, and I believe there's some contact information there with Glytec if you have further questions. So thank you very much.